And good morning, everyone, and welcome to PerfWeb 96, this very special edition of PerfWeb. My opening remarks are going to be uber abridged today. See the scroll bar down below? Every bit of information you need will be there continuously throughout the program. Now we're going to throw up another quick slide. These are very important. These are two GoFundMe pages for Denise Bazaldua and Elisa Brown, and also Life Gift. You can click on the QR codes. At the end of the day, these folks really need our help. Please, let's help them as much as we can. It's most appreciated. And by the way, all links will be in that you saw on the screen will be in the description and the comment areas of whichever streaming platform you are viewing us from today. Now, without further ado, I'm turning this over to our host for today's program, Thomas DiSalvio, perfusionist, Houston, Texas. Thomas?
Thank you, Joe. We have a very, very special... Oh, hey, Joe. I'm sorry, we have to take this call. This sounds like it's from the office. Hey, Sue, what's up? Fudge! Oh, sorry. Joe, we have an ECMO at St. Elmo's Fire Hospital.
Fudge.
Sue, what unit is the... You know what, never mind. Dr. Doogie Hauser is calling me right now. Let me switch over to him. Thank you, Sue. Bye. Hey, Doogie, what's up? Yeah, we're doing the PerfWeb right now. We're all here. That's okay, talk to me. What unit is the patient in? Okay. How big of an emergency is this? I mean, do we need to be there right now? Because we are kind of doing the PerfWeb. Or is within the hour okay? Okay. How about cannulation strategies? Have we talked about that? VV, VA? So we're going to do FEM-FEM? Okay. And you want to do VV. Got it. Is the patient a male or a female? Do we have any operating diagnoses? Okay. What about diabetes, obesity? How about peripheral vascular disease? Any cerebral vascular disease? Does the patient have COVID or any isolation measures? That's great. Thank you. How about hits? Okay. Do we have any current x-rays or CTs showing the vasculature? Okay, good. How about a tap and cross? That's good. Do we have enough blood in this hospital? What surgeon do we have coming up? Dr. Gregory House, famous for his quick wit, multidisciplinary expertise, and charming a new female patient on each episode. That's Dr. Gregory House? Great. You know what? Let me talk to Joe. We'll be back with you soon. By the way, what is Dr. House's ETA? All right, Doogie. Thank you so much. We'll get back to you. That's a lot of information in a short period of time. Things we deduced from this phone call, we've never actually put in an ECMO at this hospital before. So we have questions that we have to have answered. Do they have a working ECMO machine, and do they have the heater coolers necessary, the hardware? Do they have disposables, circuits, cannulas, insertion kits, guide wires, and potentially even sheaths for antegrade perfusion down the leg? What do we know about the ICU? Are the rooms suitable for ECMO? Do they have ECMO-trained nurses in these rooms? Has Dr. House ever put in any cannulas before? Does he even know how to cannulate? The exit strategy is very important here. Is the patient stable enough to transport if we're going to transport them out of the hospital as soon as we get them stabilized on ECMO? Does the receiving hospital even know that somebody's coming? Do we have an ambulance service on standby? What surgeon is going to be receiving him? We know he's probably pretty unstable, or they would have already taken him to the receiving hospital. What do we think administration has to say about this? Is there an insurance issue? Who should we send over there from our end? We're obviously going to need somebody who's experienced, and we have everybody working right now, so we got to get somebody over there. We have Vicky Carlyle here. She's our expert ECMO specialist, and we're going to talk to her and get her on the way. And also, we're going to talk to Becky about activating our emergency reserves for ECMO specialists from the staff pool, because we're going to plan on this being a long-term event, even though we may be told that it's going to be transferred out immediately. We know we've been there before. This isn't our first rodeo. As you can all tell, that was a staged phone call. But the reality of that call is very clear, that these are the stages that you want to, questions you want to ask as you get this information. And the calls never come at a convenient time, like when we're doing a presentation like this. Usually somebody's worked all day long and it's late and they get the phone call, or it's their day off and they get the phone call. After the initial shock, we have to gather information. And without further ado, let's do this presentation. First off, I want to check if anybody listening today has any problem hearing any of us. Please let us know in the comments so that we can address it immediately and not find out after the presentation's over with. There is no crying in perfusion. I am a crybaby. I cry every single time I turn off an ECMO. But I want to emphasize, we're going to be trying really hard not to cry about anything today. We are very excited to bring you today's PerfWeb episode. ECMO, it's not just a four-letter word. In today's episode, we want to give you examples of information that you need to ask when you get the call that your services are needed for an ECMO. Lastly, we want to give you the perspective of actual patients and their family. We have two ECMO survivors as guests and their family here with us. The studio is absolutely packed today with some very important people, so I want to introduce everybody to you right now. To my far right, we have Dr. Bhatia. Dr. Bhatia is an outstanding surgeon, one of the fastest surgeons that I've ever worked with, and he's critical to this talk because he was the inspiration for us to do an ECMO that at a hospital that we had limited capacity with, and what he put together saved Elisa's life. Elisa Brown is our next person. She is an ECMO survivor. She was diagnosed with a treatable disease and quickly decompensated, and that's when Dr. Bhatia stepped in and we took care of her. And we have she'll tell you her story, and Dr. Bhatia will tell you all about it as well. And Becky will also be telling you about this. Denise Bazadula, she is a very special person to me. I took care of Denise we took care of Denise at Methodist Hospital in the medical center for a very long time. She has an incredible story to tell. She's an incredible woman she's an inspiration to us all. And I'm so happy to have you here. It's fantastic. We have Vicky Carlyle. She's to my left. She is our ECMO specialist at Houston Extracorporeal Technology. She is one of the smartest nurses that I've ever known. She can tell you the details of everything that you need to know on any type of critical patient. And she's one of the educators at our facility, and also has been an educator at every facility she's been to. She's that kind of a person. To Vicky's left, we have Jane Ann. Jane Ann is Alyssa's mother. And it's very important to note that family support is absolutely critical in the survival of an ECMO patient. We're very happy to have you here and to hear what you have to say. To Jane Ann's left, we have Becky Bolkovac. She is a perfusionist at Houston Extracorporeal Technology. She has like 23 years of experience, 20 years of experience? 16. She acts like she has 23, but I'm around her. She's so smart. I'm like, so anyhow, Becky is a great person. Becky was directly involved in the admission of Elisa whenever Elisa was put in the hospital and put on ECMO. And then to Becky's left, we have Joe Basha, perfusionist, founder of PerfWeb, and probably the smartest man I've ever known in my whole life. Certainly my mentor and my inspiration for coming to PerfWeb and participating in these presentations. Thank you, Joe.
Thank you.
For our first talk today, we want to let Vicky Carlyle give a short discussion on ECMO, where and when it's used, and just whatever she wants to tell you about it. So Vicky, you have the floor.
Okay, thank you, Thomas. So just a real brief overview of what ECMO is. ECMO stands for Extracorporeal
Closer to the microphone.
Membrane Oxygenation. A little closer? Okay. Also called Extracorporeal Life Support, or ECLS. It's a medical procedure that is performed outside of the body. Extracorporeal means outside of the body. So it is an artificial organ that remains outside of the patient during treatment. Okay, it is a life support machine, and it is for patients with severe and life-threatening illnesses that prevent the patient's heart or the lungs from working properly. So patients that have lungs that cannot oxygenate the patient to support their body, usually because of respiratory failure, ARDS, severe pneumonia, or COVID-19, and they also have trouble getting rid of carbon dioxide. And it can also be used for patients whose heart cannot pump enough blood to support their body. Okay, it does this via the ECMO machine that removes blood from the patient's body, and it sends it to an artificial lung, or our oxygenator, which adds oxygen to the blood, and it removes the carbon dioxide from the blood. This is how it replaces the function of the patient's lung. The ECMO machine then sends the blood back to the patient using a pump that has similar force as the patient's heart. If the blood is returned to a vein, then it is supporting the patient's lungs, otherwise known as VV ECMO, veno-venous. If we are returning the blood to the artery, to the aorta, then we are supporting the patient's heart and the lungs, VA ECMO, veno-arterial. Okay. The ECMO machine is controlled by a perfusionist or an RN with advanced training called an ECMO specialist. The perfusionist or the ECMO specialist adjusts the settings on the machine to make sure that the patient is getting the amount of heart or lung support that they need. And that's just a real brief overview of what ECMO is.
Thank you, Vicky.
Very good.
That was a great talk. Thank you. One thing that can't be understated about ECMO is that it is maximum life support. And we don't just put people on ECMO because we want to or because we can. People who go on ECMO are at the very edge of their body's ability to keep them alive. And having said something like that, it's extremely important to know that ECMO is very limited in its capacity of location. And you'd be surprised that not every hospital has an ECMO program. Many hospitals have the capability of doing ECMO in a short-term manner, but when you're doing ECMO in a long-term fashion, you need to go to the right place and get access to the right place. So we have put together, Becky has put together a map showing the locations in the Houston metro area where all the hospitals are, and hospitals that do heart surgery and hospitals that do ECMO, because they are not the same thing. And we just kind of want to demonstrate what's available where and how 20 miles away can make all the difference between a successful outcome and an unsuccessful outcome. So Becky, tell us what you've got.
So we have this map that shows about 130 to 150 mile radius that in our Houston area that has our red stars are the facilities that are all cardiac facilities. The ones with the yellow arrows are ones that have an established ECMO program. So you can see that it is just a chance that you might end up in a facility that offers ECMO on a regular basis. But other facilities may show that may offer, sorry, we're having issues with the mics. Other facilities may be able to do ECMO that are the red stars, but they are not an established ECMO facility.
I'm sorry, a little bit closer. You need to get back.
Sorry. Thank you. So they may be able to offer ECMO for a means of not being able to wean from the cardiac procedures and the cardiac programs off of the cardiopulmonary bypass machine and offer ECMO, but they're not an established program.
That was a little disruptive. I don't know what the issue was. I feel bad, but probably I think what it is you have to be center. Like you see that if you talk like that. See how I'm talking right into it. That's how you have to do it. But that was, you did good. So I know that's uncomfortable for me to do that too. I'm sure I look pretty weird, but it is what it is, right? We have what we have. Okay. No, so can you put that map back up? So very quickly, once again, so you said there's 130 centers, 130 hospitals?
No, this is a radius. So I don't,
about 130 miles?
yes, this is a 130-mile radius around the Houston area. The red stars are all cardiac programs, but the ones with the yellow arrows, which there are only 7 of, are established ECMO centers.
Very good. Okay. Yeah, that is very remarkable because I don't think the general public understands that just because if they do cardiac surgery, as you said, you can do ECMO, but they don't necessarily offer it to anyone but their patients they can't wean from bypass during heart surgery.
Yes.
Okay, very good.
Yeah.
Okay, Thomas,
Thank
sorry.
you. Thank you, Joe.
Yes, sir.
That was a great talk, Becky. It shocks me to see how few facilities there are that offer ECMO, and I think as we get farther into our talk, you may understand why, because ECMO is such a labor-intensive and resource-intensive situation that it's really not possible to do it everywhere. But when needed, we can do it, and it's amazing what we as humans can do. It's amazing. I'm very excited right now for this part of the show because we are going to get to turn over the microphone to Denise Bazadula. Denise has prepared a very special presentation, and I am not going to say anything more until we have time to talk later.
Okay.
But you don't want to miss this presentation. Put your pen down, put your copy down, and I'm handing it over to Denise.
I hope I live up to the hype. Thank you for having me on the show today. My name is Denise Bazaldua, and I'm just going to talk a little bit about what my life was on ECMO and how we even got to this point. So let's go ahead and start. So this is my little family before ECMO. Everything was perfect. We had a daughter who had just turned 2. I was a stay-at-home mom, and I hate to use the word perfect, but that was what my life felt like at the time. And everything was going good. COVID had just started up during this time. Unfortunately, my mother did pass of COVID before this. And being a stay-at-home mom and taking all the necessary measures, I thought that my family was safe. And unfortunately, shortly after my daughter turned 2, my household got COVID, and everybody, my husband was, his symptoms weren't as severe, but mine, unfortunately, just kept on progressing. So on August the 30th of 2021, my husband made the smartest decision and took me straight to Methodist in the medical center. We barely made it to the door. My oxygenation was in the low 80s, and I was immediately admitted, and they put me on just a regular 5 or 6 liters of an oxygen tank while they had me in a holding area. And then I was granted a room in the emergency room, and during COVID, That's a pretty tough ask, because usually they can send you home on some oxygen or just make sure your oxygenation is up. Then it's a revolving door at the time. So as you can see on this day, they started me just on a regular mask, and then we had to go into Airvo because my oxygen needs kept on increasing. And then I was in the emergency room for a few days until they went ahead and said, okay, I needed to go to an IMU unit. And in the IMU unit is when my oxygen needs continued to increase. And now we had to try a CPAP. And we were on the CPAP for a while. And I don't know if you've ever been on a CPAP machine, or I know a lot of people usually have to sleep with one, but how anxious it makes you and how claustrophobic you feel, and knowing that you needed to breathe but you want to take it off at the same time. It's such a battle within yourself, because you need it, but at the same time you want to take it off. So it's a necessary evil. And we were on the CPAP for quite some time. And I was in the IMU unit for maybe less than a week when my oxygen needs continued to increase. And we were told it was time to go ahead and transfer me to the ICU. So when I was initially admitted to the hospital, it was August the 30th. My birthday is September the 16th. So now I am in the ICU, still on a CPAP machine, but I was able to celebrate my 33rd birthday in the hospital, and the staff was amazing. During this time, you weren't able to have any visitors. I was trying to FaceTime my family on a daily basis, and the staff just really went above and beyond on making sure I felt as comfortable as I could and as loved as I could during that time, just given the situation and the emotional toll it was taking on me. So this is me celebrating my 33rd birthday in the hospital on a CPAP machine. And the day after my 33rd birthday, I had to be intubated. So the decision was made. My husband talked to the team. At that point, we had exhausted all of our resources, and I was still declining. So I was intubated and sedated for about 3 months. So during the majority of these 3 months, of course, my family wasn't able to see me, not until the end. So we did a lot of FaceTime calls. I didn't really have an idea of what was going on besides the delirium that you do experience when you're intubated in an ICU setting. At this point, it was just really tough because I'm intubated, and seeing my mother go through all of these things, to me, intubated meant I'm not going to make it. There's really nothing else, that we can do at this point. So it was a very challenging time for my family, having to see me get to this point and knowing that there's really nothing else we can do. We're literally living on a prayer and hoping that the medical team can come up with a solution to help me get better, see if I can get to the point where I can even be extubated. And this brings us to where I was finally able to be extubated, and I was put on a trach collar. So during this time, I've been in a coma, in sedation for about 3 months. So I'm not able to lift any of my extremities. I do have my memory, but I cannot speak. Obviously, I don't have a Passamere valve at this time. I'm not strong enough to do anything. But my family, again, they came through and they learned how to read my lips. We used communication cards, and we were able to FaceTime, and I was getting to a point where they began to let me see my daughter, because at the end of this all, I'm still a mom, I'm still a wife, I have a life outside of my current situation, and my number one goal is getting back to my family. And I'm understanding everything that's going on now. But as a mom, I just want my baby, regardless of my situation, regardless of how I look. I cannot move forward until I see my baby. So luckily, the staff moved mountains. My husband was my biggest advocate and made sure that we were set up to where my daughter was involved in my care. And I'm very, very grateful for that, because had he not advocated so much for me and the importance of us continuing to be a family unit through this difficult time, we probably wouldn't have made it as far as we would have made it. So I've been extubated, and I've been working with physical therapy for a while now. Our goal was to see if my lungs would pretty much just fix themselves. Maybe they just needed a break. And unfortunately, that wasn't the case. In about June 2022, that is when my health began to decline again. I was on the maximum amount of nitric they could put me on. I was on so many pumps that there was nothing else that they could do. And then that was when I was a candidate to be put on ECMO. And that decision was made, and it was one that was not taken lightly. I'm very grateful to have been in a facility where an ECMO machine was available for me, and that I had the team with the knowledge that knew exactly when it was time to go ahead and enter the ECMO. I had a VV ECMO because my issues were my lungs, and I was cannulated at my neck site. And it was a very, very scary experience. I was awake when the talk about me being put on ECMO came about. At that point, I had no idea what ECMO was. They just said it was the highest form of life support, and it was my only chance to see if I would get better while we found me a lung transplant. And so at that point, I said, anything we can do to keep fighting, right? Little did I know I was signing up for the biggest fight of my life. Being on ECMO is something that I'm very, very grateful that it is available. And I just hope you never need to use it. I hope you never need to use it, because it is a lot. My husband remembers after I get after I was cannulated and I woke up, I said, whose idea was this? Whose idea was this? We should have gone the opposite way, because it's a lot. It's very taxing on the body, and you're told what your chances are, you're told what your odds are, but you have to keep your eye on the prize and know why you're going to fight, and know that this equipment is here to fight for you medically, scientifically, but the other fight has to come from within you. And you have to trust your team. You have to trust your support system. Most importantly, you need to trust yourself to know that this is going to be a road. For some, it's short. For some, it's longer. But ECMO is more than just the machine doing it for you. It's the patient having to put themselves in the mindset of, I am going to fight with the help of this machine, with the help of my team, to get me off of this, or to get to the bridge to wherever ECMO is bridging you to, right? So this is me learning to live my life with ECMO. Like I said, I was cannulated in June, and I was on ECMO for a total of 311 days. I know that is a long time. I've heard of most facilities, only like to use ECMO for a couple of weeks, but by the grace of God and my team, they went the extra mile for me. And I just had to know that this is my life for this season. Won't be my life forever, but this is the season of my life that I'm in, and I need to embrace it and learn to live with it, because this is going to be my life every day until we can get to a transplant. So it was really just that attitude of saying, okay, this is my current situation. How am I going to make the best of this? And I cannot control this. I'm very limited in my movement. I'm very limited in what I'm about to do, but I'm not going to let that define who I am in this moment, because even when in the moment where they tell you all the odds are against you, you're still alive, and you're alive for a reason. The big part of the reason why I'm alive is because of ECMO. I believe in my hospital, they named every machine. My machine's name was Bruins. So it was just me and Bruins in that room. And we had a love-hate relationship. And we said it was a marriage that I couldn't wait to get a divorce from. And, but yeah, ECMO is a really big thing. And in my facility, being able to do physical therapy was my number one, because I'm getting ready for transplant. So it's very important that I stay active. But I'm also on ECMO. So what can you do when you have to have a team of people just to get you out of bed? And we had the best team, and I was able to ambulate. I was able to do tons of physical therapy with my ECMO, and a typical day for me looked like I would have a perfusionist. I needed 2 people for physical therapy. I needed a nurse, and I usually would have somebody in my family support team. It took all of us to just get up and get me to walk. It took all of us just to get me to move a chair from chair to chair. So it's a big team effort to ambulate somebody who's on this type of life support, but it can be done. And it's very important for, as a patient who's on ECMO, to push yourself, and the team may be uncomfortable because there's so many wires. Oh my God, there's so many wires. One trip can, end everything, but you need to let your team know that we're going to take this nice and slow. Let's build some trust, and let's push the boundaries a little bit in a safe way. So again, this is more of, like I said, I was cannulated on my neck site. This image shows a little bit more of what it was and how my halo, or the cannulas, would go over my head. And you can also see a little bit of where my trach was, and how I did have, at this time, my Passamere valve. So I'm able to communicate with my daughter. And that was difficult because, those with little ones, this is a lot for them. But it was very important for me for my husband and I, to let our daughter know that mommy is in this situation, but we're going to embrace every situation we're in. Let's not be scared. We're going to make this hospital setting as much of a comfortable setting as we can make it for you. But through and through what we're going through, our family unit is going to remain strong, and we're going to be together regardless if you have to go home and sleep with daddy. But once a week, you're going to come and you're going to spend time with mommy, and this is what our life looks like. So at this point, it's another turn around the sun, and I'm able to celebrate my 34th birthday in the hospital. And actually, you can see Thomas on one of the slides there. He was my perfusionist the day we went down we went down to the lobby and got some Starbucks for my birthday. But you can just see here how the hospital and the physical therapy team, the perfusionist, everybody who just comes together, and how this process is just more than one person, how you really need a team of people to care for a person who's on ECMO. And there's actually another patient who's in this picture with me, she was an ECMO sister. She, at this point, she's already transplanted, but her and I, have similar stories. And so here we are, two people that were on ECMO, and with our team, and we're still able to celebrate, and we're, we have energy to keep on going. Yes.
When you went to Starbucks, did you get to go to the front of the line?
I did get to go to the front of the line. And I try to pull that card now that I'm not on ECMO, and it doesn't work.
Joe,
I did. Okay, forgive me. So I have to ask the question again. When you went to Starbucks, did you get to go to the front of the line? So I have to ask the question again. I think everybody heard your answer. Is that better? Thank you.
And yes, I did. I pulled the I'm on life support card.
yeah, I was actually. So I'm standing there, and I've got the ECMO machine, and there was a line of people, and of course a lot of employees, and the employees do not have much time for their break, and they want their coffee, and they want to get it and get out of there. And along comes Denise, and she walks up and she goes, but she couldn't talk very loud. She goes, "I'm kind of on life support. It's kind of a big deal." And so everybody's like, "Whoop," everybody got out of the way, and this like mass of people, carrying the machine and carrying it. Also to be with you on your birthday, it was a very special day.
Yes.
I better let you talk more. Sorry, I'm gonna.
It was. So it's definitely at this point I'm celebrating 2 birthdays in the hospital. So bless the staff. And a big part of doing this, it was my concentration on why we're doing all of this, right? Because being on ECMO, for instance, I was waiting for lungs, but you also develop other issues. So you have the blood that's recycling in your body to act like your lungs. But I also developed issues with my right ventricle and my heart. And I was having issues to where, just for to break it down, it was either I was going to die because of my heart, the right side wasn't getting enough blood, or I was going to die because we were on ECMO a little bit longer than what some may seem ethical, or I wasn't going to get a pair of lungs. So you have to really be honest with yourself and know that these are your odds. You are trying everything that you can, but why are you trying? Why do you continue to fight? And this is my reason to fight. It's my husband and my daughter. And I want nothing more in life than to see them grow and be the mom that I once was. And so that was a big portion for me. I would hear the odds, I would hear everything, but at the same time I would say, okay, but I'm not giving up just yet. I still feel like I have more fight in me, and I'm not ready to quit. And being in the hospital for so long, you miss out on the little things. And for example, I hadn't been outside. So again, the team was gracious enough to plan little field trips for me just so I can go outside and feel the sun. But even doing that, you see how big of a team it takes just, to let somebody go outside for, 15, 20 minutes to be able to feel the sun. So here we have a physician's assistant, a perfusionist. We have to have an ECMO specialist. We have to have a respiratory therapist. We have to have multiple people for physical therapy. We have to have 2 nurses. And then, of course, I always had somebody in my support system. But just to let you know the magnitude of people that it takes to be able to take one patient who is on ECMO, out of the unit, right? So this wasn't done too often, but the fact that the team made the time to do something just as simple as letting me go outside so I can feel the sun is just something that I would never, ever take for granted. So kudos to everybody who goes above and beyond for their patients to just let them experience something as little as feeling the sun. And then, so now I got the call. The moment we didn't think would ever get here. And on May the 2nd, in the evening time, we got a call saying that they had found a donor for me, and that the lungs were a good match, and if I would be willing to accept them. And of course, the answer was yes. So here I am signing all of my paperwork for my lungs, getting all those the lab work done, and finally being wheeled out to the emergency room. To the operating room on May the 3rd. It's May the 3rd now. And being in the hospital so long and being on ECMO so long, you really get to build a rapport with your perfusionist team. So I remember some of the perfusionist team, they were all waiting for me down in the operating room once I got through the doors. I would tell each and every single one of them, whoever is working the day I get the call, please just hold my hand until I go to sleep. Because, you're not going to know anybody in the operating room. And I knew all of my perfusionists. I'm like, just hold my hand until I fall asleep. So it was such a blessing to be able to go into the operating room and to see so much support from all the perfusionists and everybody, to see so many familiar faces before the biggest surgery of my life. And this was a post-transplant. So I no longer have my halo, no longer on ECMO. And it was a tough recovery after transplant, but it's one that I will hopefully not have to do again. But if I do, then I'm prepared for the fight. And it just shows, how remarkable ECMO did its job. It was my bridge to transplant. And here I am post-transplant, and I would have never made it this far had I not had the opportunity to be on ECMO. So I'm very thankful and I'm blessed. This is me having my first meal after ECMO, and as you can even tell, my skin looks different. I look like a brand new person, and some of my scars from where I was cannulated. I'm sorry, not cannulated. I'm cannulated at my neck, where my ECMO is placed. And then these are just some of the scars that I wear with pride, and I'm happy to tell anybody who would listen that I am an ECMO survivor, and what ECMO did for me, and this is me finally being discharged. So that day was June the 8th, and we had a party down in the lobby that lots of my team members were able to join in on, and it was very bittersweet. I did not think we would ever see this day after being in the hospital for so long and just being told what our odds are, but here we are, by the grace of God, being able to be discharged and finally going home. So I finally got to go home and hug my daughter in the comfort of our own home. I was discharged on June the 8th. I spent 311 days on ECMO and 21 months in the hospital, but this was my goal. This picture right here was why I fought every day and why I continue to fight every day, is to be the wife and mom that I want to be. And now we are 6 months post-op, and I celebrated my 35th birthday out of the hospital, but with the medical staff. It was only fitting to go out to lunch with some of the staff members on my team, as it being my first birthday out of the hospital. So here is some of the nurses and physical therapists that took great care of me during my hospital stay. We're celebrating my 35th birthday in the middle, and I missed 2 of my daughter's birthdays, so I was finally able to celebrate her 4th birthday with her. And then now, our family is we're making new memories together, and it wouldn't have happened if we didn't have ECMO as a bridge to transplant, and if I wouldn't have had an organ donor as well. So I thank every perfusionist, every ECMO specialist, every surgeon, every organ donor, every family who decides to give the gift of life, because for that reason I'm able to be here and make new memories and to share my story in places like this. So thank you.
That was very, very, very nice. I really enjoyed that, and it's very emotional, very touching, and I compliment you on your will to survive. Really, that's what you're talking about, and what it comes down to. Mm-hmm. Very good. So now, in contrast to ECMO being used as a bridge to transplant, ECMO can also be used, of course, as a bridge to recovery. Dr. Bhatia, I think you're going to switch sides with Thomas, and he's going to get your slides set up for you. Can you do that, or do you know how?
I think I can do it.
Okay. And if you would be kind enough to go over there and give your lecture on Legionnaire's disease, Legionella, and present Elisa's case as you found her. No, not yet.
No.
We're doing it in order, on the order.
And no, I can't do the slides.
Uh-oh.
Yeah.
Something fell apart. Do you need help?
Yeah, we're going to need help. That's your phone.
Yeah, it's okay. Thank you.
Joe to the rescue.
Yep. Files.
I got it.
Yep.
Okay. Legionnaires. Slideshow. Concurrent. Okay. Are we set?
How do you advance?
Like that.
Okay. All right.
And if you want to point to something, you just hold your finger on it until the red light goes up.
Okay.
And move it.
All right.
Okay, sir, I think you're up and ready to go. Dr. Bhatia will be presenting Legionnaire's pneumonia, or Legionella pneumonia, as we call it. And Dr. Bhatia, thank you.
Well, thank you. I must say that was quite a wonderful presentation,
Thank
very
you.
moving, and gives us, I think, a lot of reasons to get up every day and go and do what we do every day, to see
Thank you.
success stories like you and Elisa. And so I'll start by talking a little bit about Legionnaire's pneumonia. This is a natural occurring waterborne bacteria that thrives in warm water and warm, damp places. And it's commonly found in lakes and rivers and creeks, but it's also in the community, and it can infect humans as a community-acquired pneumonia. It's a gram-negative bacilli. It grows as parasites within free-living protozoa and within biofilms. And you can see the microscopic examination of the gram-negative rods in the upper left. The most frequent disease outbreaks are typically in hotels and resorts, but also in long-term care facilities, hospitals, senior living facilities, and even in the workplace and community. The bacterial transmission can be from drinkable water, cooling towers, hot tubs, industrial equipment, and even decorative fountains. The history of how this became the name was at an American Legion convention in 1976, where 221 cases of Legionella pneumonia was diagnosed. 168 people were hospitalized and 34 people died. And for this, Legionnaire's pneumonia was named. The infections are primarily respiratory. They're contracted airborne, not usually transmitted human to human. There is a self-limiting influenza-like illness, which is typically how patients will present. It's usually incubated between 24 and 48 hours, and it usually just lasts 2 to 5 days. Typical symptoms are fever, chills, headache, muscle pain, malaise, and typically no deaths. It's an atypical type of community-acquired pneumonia, and Legionnaire's is, again, the initial symptoms are fever, loss of appetite, headache, malaise, weakness, and lethargy. Hemoptysis can occur in about 1 out of 3 patients. Patients may also have muscle pain, diarrhea, and confusion. Untreated Legionnaire's disease usually worsens within the first week of presentation. Most frequent complications are respiratory failure, followed by shock, kidney failure, and then multi-system organ failure. Recovery is always required with antibiotic treatment. One thing that we are seeing is an increased incidence of Legionnaire's disease, I'd say primarily because of we're looking for it more, we're able to diagnose it more, it's being reported more in hospitals. There's an estimated 8,000 to 18,000 people who are hospitalized each year in the United States with this disease. 75 to 80% are over 50, and 60 to 70% are male. And underdiagnosed and underreported cases, it may be as high as 1.8 to 2.7 times as initially reported. This is an X-ray of a typical patient who would have Legionnaire's pneumonia. The overall mortality rate is anywhere from 4 to 18%, but those that require intensive care unit monitoring can have up to a 20 to 30% mortality. The increased risks of death have to do with advanced age, smoking, chronic lung disease, weak immunosuppression can also contribute to mortality. This X-ray is very typical of what we would see in somebody who presents with Legionnaire's pneumonia. The diagnosis is done by culture and a urinary antigen test, and in this case that we're talking about today, that's exactly what was done. The treatment is, as I mentioned, with antibiotics, fluoroquinolones, macrolides, and tetracyclines. Supportive care requires oxygen administration, intubation, fluids, bronchoscopy, nebulizers, blood pressure support, and possible ECMO. So now we get to talk about our second patient who's on the stand today. This is Elisa, who is my patient, and she was admitted to the hospital on September 13th with just a routine community-acquired pneumonia. I did not get to know her until about 1 hour before she was going to die. And she presented to the hospital with some shortness of breath and chest pain, and X-ray showed what you see here. This is actually her X-ray. Wow. She had a very rapid decline and required intubation. And on that Friday, I believe, September 15th, I received a call from our intensivist who had the wherewithal to call and said, look, I need some help. And kudos to Dana Woods or Martin. I don't know which one it is today, but she's actually a great intensivist. And she called and she was, listen, I think that we need to think about putting Elisa on ECMO. And so at that time, I got up from the dinner table and ran up to the hospital and saw Elisa intubated and sedated and paralyzed and about as purple as a grape. Literally, oxygenation was horrible. Her saturations were in the, I guess, the 60s or 70s.
High 60s, low 70s.
That's not compatible with life very long. And I could tell, even though she was sedated, she was struggling. She was diaphoretic. She literally was, in my opinion, within 1 hour from dying. And we started on some blood pressure support with Levophed and dobutamine and made the decision to take her to the operating room where we were going to place an ECMO, a VV ECMO, much like yours, through the right neck. And I will tell you, I'll diverse just a little bit because or divert a little bit because we did go to the operating room. Everybody was ready to go, and we got there, and we didn't have a cannula. And for a minute there, we were like, okay, what are we going to do? And we realized that there was a nearby hospital, and Joe got in his car and drove 100 miles an hour, I think, to go get it and bring it back. And then we were able to successfully place the cannula in Elisa. The initial findings when I came, as I said, she was in distress on pressors. pH was, again, barely compatible with life, 7.19. Her PCO2 was 70, and her PO2 was 30, clearly showing a very severe case of inability to oxygenate and ventilate. She was cyanotic. She had respiratory metabolic acidosis. Heart rate was about 140. And so on the 18th, Legionnaires was identified. She had multiple runs of VTAC and heart ectopy. We started her on some cardizem, and that seemed to settle things down. I'll show you a video of a bronchoscopy, but I do want to make a point that when we were in the operating room and we were able to successfully place the cannula, it's just amazing to see how oxygenation of blood and how patients look before and after. And it is an immediate recognition, immediate clear notice of somebody being purple to pink. And that's exactly what happened. Her oxygen went from 30 to 40 to 280 immediately, the minute that we begun the circuit. And it was just amazing to see that sign of life. And I knew at that point that we had a chance to get Elisa through this. And so this is a picture of a bronchoscopy or video of a bronch. And you can see
Video. Okay.
how much is within the airways of the bronchus and the lungs. And this is why it's so difficult to oxygenate somebody that has severe community-acquired pneumonia like Legionella. So on the 21st of September, a few days later, we attempted to wean off her paralytic. We had an oxygenator change out a day later, and continued on the support to get her on the road to recovery. You can see this is an X-ray after placing the cannula in the right IJ and down through the heart into the right atrium and inferior vena cava. You can see that cannula there. And again, we can see the lungs that are severely involved with Legionella pneumonia. She also had a trach that I performed 10 days or so later, a couple weeks later. And her oxygenation and her ability to ventilate slowly started to improve. The X-ray, it got worse before it got better, but it did start getting better. And before you knew it, we were able to actually get her off the ventilator. ECMO was still doing its job and still running. However, we knew that we could start weaning the ECMO as the chest X-rays started getting better and her clinical situation started improving. So we were then able to decannulate quite a bit sooner than 300 and something days, but this was, like Joe said, a bridge to recovery. Her chest X-ray did improve, and she was able to respond to the antibiotics, and the lungs slowly cleaned up, and we were able to get her off of ECMO following a trach and getting off the vent as well. So this is Elisa, much like the pictures that you've seen earlier. And I know you recognize these, right?
Oh, yes.
But like you, Elisa was a fighter, and I knew that she had the desire to survive, and she was very coherent, pretty much with everything that we were doing, and she listened and really worked hard to get herself in the position where she is today. So this is, as you can see, the ECMO is in the right IJ. She has a trach at this point, but she's awake, and they're in the process with the physical therapy to get her up and about. And even though she was on full support ECMO and a trach, she was able to walk in the ICU and get stronger, so we could then subsequently wean from ECMO and decannulate. And we were able to do so, and then this is her up in the up on the floor out of the ICU, doing again additional physical therapy, and continuing to get strong and stronger. And then this was after I took the trach out, and she's actually in a room now with nothing, no cannulas, no trach, no oxygen, walking the halls and getting ready to go home. And there she is in the car, heading home, and you know, we were like the treating team at Methodist. Our team was very proud and very happy and very excited that we were able to get her in this situation and where she is today. So.
Dr. Bhatia, thank you for that presentation. I said it once and I'll say it again. You saved Elisa's life. You brought together a team that was not there. And I know that we all worked very hard to get there for you and for the patient, for Elisa. And I think we're all very proud of the success. And we're so happy for you. And that was a great presentation.
Yeah.
Thank you.
You know, it's interesting. There was some talk initially here, this meeting, about only 5 or 6 or 7 facilities in the city of Houston that are equipped to handle ECMO. I think it's it's amazing accomplishment that we had a team that could put together a care plan and treat Elisa in a facility that really wasn't set up to do ECMO. I think we're much more set up and ready to do this now, but you know, we had a willingness of everybody on the team and the family support and the patients, and you know, everybody just came together, and we're just very happy that we were able to get this outcome.
Yeah, that's fantastic. Thank you very much for that talk. We're going to move on for perfusion involvement in this case. So since PerfWeb is a lot about perfusion, when perfusionists first got this call, the person receiving this call was Becky. Becky then called me and said, hey, can you come in? And I was actually already busy, but I said, hey, if you need me, call me. She didn't call me back, but she called Joe. So Joe got involved. Becky's going to discuss her involvement in this case and what she did to get this situation ready to go for perfusion from our perspective, including the infamous cannula rescue.
So when I received the call to go, I was actually picking up my kids from daycare. So, you know, living life and doing the normal things outside of work. And I believe when I got the call, we were just being made aware that we were going to check on a patient that may be in need. And then maybe just like 10, 15 minutes later, I got the call back that we were going to definitely initiate Elisa on ECMO. And so when we arrived, we set up everything, and we actually realized we did not have the particular cannula that we needed for Elisa because we were in a facility that is a non-established ECMO facility. So we are mostly prepared in that facility to go on ECMO for patients who cannot wean from cardiopulmonary bypass and or are in cardiogenic shock, with the intent to possibly transfer out the patient so that they can be cared for elsewhere, because again, we're not an established facility there, so we do not have the team or the personnel in place to take care of those patients long term. So obviously one of the first thoughts I'm thinking is, when I'm going in, is, are we going to transfer out? And I think that was initially our intent, was to transfer Elisa out after we initiated, but it turned out that she was unable to transport. So after cannulation, a few days had gone by before we had realized that that was actually going to be the case. And so now we really have to think about staffing, because we do not have an established ECMO program there. We don't have the people credentialed there to take care of this patient. So we're in a situation where we have to emergently try to get or quickly get people who can come in and sit with her, because it's 24-hour care, and put those personnel in place to care for her the best we can. We ended up with a great team. Houston Northwest is a great team of ICU nurses, and our perfusion team and Dr. Bhatia, all getting in place and putting it in place as quickly as we did, and Joe getting the cannula as quickly as we did. We were able to save Elisa. And that's not always, you're not really sure in the beginning of initiation what obviously the outcomes are going to be. It's a last resort. It is the last thing we can possibly do to try to save somebody's life. So you just don't know what it's going to be like. And so when you turned around and you start to see some improvement, you're on the right track to survival. So I'm really, really in awe, actually, of both of your stories, Denise and Elisa. And I loved hearing about your side of your experience. And I'm just in awe of it. Thank you for being here and sharing it with us.
Thank you.
Yeah.
Very good.
Thank you, Becky.
Very good. Okay,
Yeah.
Thomas, next.
Yes. So we are at a point in this talk where I just kind of want to have a quick discussion with Denise, just a few simple questions. And we have not scripted this. We have not taken the time to. I didn't give her any of the questions ahead of time. And I did not know what I was going to say. I can tell you that prior to this show, I received Denise's videos, her talk. And I immediately sent it to Joe Basha first, because we're going to put this on the show. And Joe, he looked at it and immediately came back, and all he said was one word: wow. To look at your presentation on paper elicited such a strong emotional feeling. To hear you say it was on another level. And my first question for you is, do you know how many pictures are in your presentation?
No.
It's a trick question.
And the funny thing is, I have a sister who has always just taken, she's our family photographer. So she has been taking pictures since I was intubated. I mean, I have a gallery of my journey, and it's a little weird then, but now looking back, I'm very grateful that I have all of those memories to go back and look back on, because I have a slew of content to go back and make sure we remember.
Share the word.
Yes,
Yeah.
yes.
There's 45 pictures in there.
Oh, is there?
Yes.
45 pictures.
You were able to condense your talk that lasted 21 months into 45 pictures. And they were powerful. It's very, very impressive. I have a question for you about your knowledge of ECMO. Mm-hmm. You are probably more qualified to be a perfusionist than all of us in the room right now.
Well, the funny thing is, before all of this, I had no idea what ECMO was, anything. And then, obviously, I was on ECMO, and I just started seeing, and I ask questions all the time, and so I'm asking questions, and I'm asking about what is the sweep, what is the PEEP. I'm like, if I could turn back time, I want to be a perfusionist, because you do a little bit of bedside, but you get to see the behind the scenes stuff. Like the machine is so complex. There's just so many things, to it. And I was just in awe of what ECMO is, what a perfusionist does. So it's a field that I had no idea existed, and it is such a vital part of healthcare. Such a vital part.
One of the things that we did a lot when we walked, we listened to music. And I'm just curious. First off, I want to thank you for the education in music because I know nothing about music. I can sing songs, but I don't know who sang them. Sometimes I hear an artist, I know who the artist is, but I don't know what songs they sang. I just kind of, Denise educated me on music the entire time. And one thing that's interesting is in your pictures, you have this smile. You're on artificial life support. It's the most technologically advanced thing that we offer, and you're smiling. And your attitude was infectious, and you were the best advocate for your team. You know, I know you had great advocates around you, but you were definitely the greatest advocate. I'm curious, did you know that I used to go in the mornings whenever I was there, and I would always take a quick look at you? Did you ever remember any of that?
Sometimes when I couldn't sleep, I would remember you walking in. I'd say, "Hey, Thomas."
Yeah.
And, you know, you'd take your little numbers, and you'd sneak out. In the beginning, I didn't know that you guys would come in and jot down the numbers. Or sometimes I was awake. But y'all work all the time.
Yeah. So Denise would always be smiling, and she would say, "Hi, Thomas." And I would oftentimes I would just want to leave because I felt so bad for you. But you know, sometimes I would come in the room. There's a few times where I came in the room and you were not, "Hi, Thomas." You were like, "Hey," and I was like, "Oh no." And the number of infections that you had and everything is very critical because we can't mess this up. The slice things can mess things up. I was curious, did you know about any oxygenator failures?
I know we had to have the oxygenator replaced, and I think we also replaced the circuit, and which that was obviously when they put you on ECMO, you're in an operating room setting, and you're sedated. You don't know anything that's going on, but when they actually changed the circuit and the oxygenator in your room, and you see the amount of people that come in, and you have doctors, they have all these life-saving, literally the nurse had like, I don't know the name of the drug, but something to shock me if I, you know, passed out at that moment, just to change a circuit or an oxygenator and all the bags that y'all would put the old cannulas in and everything. So I remember we did have to change the oxygenator, we had to change the circuit, and then I know we had to also change the heater a couple of times.
Yes. So besides the normal change-outs that normally occur because oxygenators degrade over time, we did have two actual, they were malfunctions, they were pretty serious, and I know you were aware of them. And we had to do, you know, some rapid change-outs. Whenever you are being changed out of an oxygenator, how did you psych yourself up for that time period? Because I'll just say this. I time lots of people whenever they change oxygenators. They don't like it, but I time people, and I time myself every single time. And the fastest I can safely change out an oxygenator is 40 seconds. And the truth is I can do faster, but I use the word safely. And because you have to give it those extra time to make sure that the connections are secure and there's no air. It takes 40 seconds. Now that means you're holding your breath for 40 seconds. How did you mentally prepare yourself for that? And that's on the good side because a lot of perfusionists
I don't
are
think
longer than that.
you can mentally prepare yourself for that. I just have to trust that my team is going to bring me back if something happens. You don't know what's going to happen in that instance. I have confidence in my team, and I know that y'all have all the tools in place to do things as quickly and as safely as y'all can. And we knew that I'm on ECMO and I need my oxygen, and I was just, let's go. Let's see how fast we can do this. But I knew that the team was there, that everybody was on standby, and everybody was going to move as quickly as we could. So I don't think I was really concerned about it, like mentally worried about it. It was just more of a sight to see when you're, awake and you're looking, it's like NASCAR. It's exactly like NASCAR.
is.
Everybody
Yeah.
is in position. Yeah.
Yeah.
Yeah, like a pit stop. Thomas, just in deference to time, do you have maybe one more question that you could ask, and then we need to sort of
Right. Thank
keep
you.
moving on?
Yeah.
I'm
So
sorry.
I guess I'm going to skip to the question that I think is really important. Were you aware of the amount of emotional preparation that your daughter underwent to be able to see you in the hospital that Methodist provided for her?
Now I am. In the beginning, there was a lot that went into that, because at that time, with the ICU restrictions and the COVID guidelines, children were obviously, she's 2 years old. She was not allowed to be anywhere near an ICU. I think that we worked with music therapy a lot to help engage her and let her know what was going on. Texas Children actually stepped in and provided a doll with a trach and tubes. That way she had a baby doll to look at and say, mommy has, a PICC line, baby doll has a PICC line. And that really helped. And I can say that after the experience that we had with my daughter, Methodist has actually come up, has created a team to help people in a situation like ours, to help bring little ones like this in with their parents, and how social work and music therapy and everything can come into play. So I think we were one of the first ones that did that. But if this positive outcome came from it, then I'm happy that we were sort of used as the guinea pigs and see what went wrong and what we can go off of now, because now Methodist has better plans in place for situations like mine.
Yeah, that's awesome.
Very good.
Yeah. So we want to turn the talk over to.
Do you want to show Denise's well wishes, or would you like me to interview Elisa first?
I think-
Denise's well wishes. Do you want to do that and then show the well wishes videos one after the other?
Yes.
That'll
Yeah.
work for me
Yeah.
too. So, Elisa, you've been very quiet. Okay, and I'm sort of used to that. You're kind of a quiet girl. I think that's your basic nature. But how did your illness begin? What do you remember?
I just remember I started not feeling well around the 9th of September, and normally I just take medicine and push through and go back to work, but nothing seemed to be working, and I finally went to urgent care on the 13th, and the doctor there took one look at me and said, "Oh, no, you need to go to the hospital. She knew instantly that my oxygen levels were low. So that's when they sent me to the hospital. And I don't remember anything past the 13th. Even though I went into the coma and all that on the 15th. From the 13th to when I fully woke up, which I think was on the 27th, I don't remember anything.
Yeah, that's very interesting. I'm curious, though, why did you not go to the doctor sooner? I mean, you were obviously sick. You were getting sick. You felt it. You knew you were getting sicker. You weren't getting better. What was the differentiator there? Why did you not seek medical care sooner?
Just because I don't think that I've not had to before, and I just thought that this was just something that I was just going to get over like any other time I've been sick. But it got to the point to where I was stumbling around at work, so I had to go. There
Understood.
was no.
What was the first thing? So you don't remember your hospital admission, you've said. What is the first thing you remember when you were in the hospital? Because your coma, of course, was induced by us. You know, Dr. Bhatia ordered sedation and paralytic. We did a lot of things so that you wouldn't have any awareness. what is the first thing you remember when you woke up?
Just my mom being right there. I was restrained. My legs and hands and stuff were tied down. I was confused. I had a whole conversation in my head apparently that didn't actually happen. It was a lot to take in. I thought, for all I knew, I thought that I had left the hospital after that Wednesday on the 13th. So, and that it was already October when I woke up. It was just really weird, the whole experience, and pretty much not remembering 2 weeks of my life, thinking that it's already this, but it wasn't already. It was, yeah.
Yeah, it is very strange. Do you have nightmares now?
No.
No. Do you remember do you remember something and try to, like, was that real or not? Do you wonder, or do you have any memories that come back now about that time? Like, do you
No,
remember getting
not
up
yet.
the first time on ECMO, having to sit at the edge of the bed? Do you even remember that?
I do remember sitting up for the first time after waking up and like working with Brock that first day after waking up. But as far as people are telling me that I was responsive and blinking and nodding prior to fully waking up, I don't remember any of that.
Mm-hmm. Very good. So how are you doing now?
I'm doing good now. Physically getting stronger every day. Emotionally, it can be a little hard sometimes. For the most part, I'm okay. But when I'm sitting there and I just kind of get lost in thought, I do have my moments where I will kind of just break down, have a little cry, and then I'm okay.
Mm-hmm. Do you remember my advice?
Yes.
Mm-hmm. Have you followed that?
Yes.
Very good. Mom, got some questions for you.
Yes, sir.
What went through your mind when Dr. Bhatia walked out into the waiting room and said, your daughter is going to die if we don't do this and we need consent?
Well, that's awfully hard to hear when you're the parent. We knew that she was really within hours of dying. Dr. Woods, when she was on the ICU floor.
She's watching, by the way.
Oh, hello. You're wonderful. Thank you for saving my daughter's life, all of you. She was very distraught and wanted us to know that this was the last support that they had to save Elisa's life. And I'm very grateful that the team was able to work together, were able to find the cannulas to do the surgery and to put her on the ECMO machine.
Mm-hmm. So what was it like day after day? Because, you know, these patients, and Dr. Bhatia, I think, explained it very well. There's a honeymoon phase. You get them on ECMO, and they immediately they look better. They look great. You think, okay, we can take this out now. They can go home. But then over the next several days, they get worse and worse and worse. And there's this period of time they look great, then they deteriorate, and all the other issues pop up, like other infections and bleeding and all of that. So what's that like as a family member to see all that's going on day after day?
I will say that I was kind of prepared for the IVs and the lines that were in her. I was not prepared for the cannula and the actual ECMO machine when we saw her. I think my husband and I were both just amazed. There she was. We tried to talk with her every day to let her know that we were there, that we were supporting her. We played music for her. It was hard to see her every day not responsive and just hoping that, you know, when we came back to the hospital the next day, it was going to be the day that she would be able to open her eyes. And it took a little while, and it was certainly a red letter day in our family when that happened.
Yeah, in fact, I've got Dr. Bhatia and the team here. I've had to distill down 10 questions or 11 questions. There's too many questions, so that's going to be an issue. And how about you? Have you followed my advice?
Yes, sir.
Good. And I will tell you, I remember Dr. Bhatia, and I'd like for you to describe this if you could, when we walked out of the room where you consulted Elisa's mom and dad, and when we got far enough away, you looked at me and you said, "Did you see your dad?" And he doesn't want to be on camera, but you saw a picture of him.
Yeah.
You want to describe that moment?
Yeah, you know, it's one of these things that, you know, we do procedures on people every day, and you can, you know, get into a sense of repetitiveness, but in the end, you got to realize that these are human beings who have family members that, you know, that love them very much. And, you know, when I came in to speak with the mom and dad, and you know, I was very straightforward with them, saying that, you know, we are within hours of dying, and I am going to do this. I'm going to take this on and do this. And you know, you see, you know, family members who are holding on with just this one glimmer of hope that, you know, this is going to work and we're going to be able to save their loved one. And you know, I'll tell off on the dad a little bit because I saw some tears, and you know, it's obviously a great sign of the love that they both have for Elisa.
And the fear that they're feeling at that moment.
Yes. And so, but you know, it's a battle, and you're preparing to go into battle when this kind of thing happens, and we're able to pull it off with good success.
Outstanding. Elisa, Mom, I call you Mom, him Dad, and that it's Elisa. Thomas, I think we have 2 videos to play. So, David, if you would be so kind as to play Denise's video first and then Elisa's video second, we would appreciate that so much.
Hey Denise, it's me, Summer. How are you? Just wanted to send you a message telling you how much we all love you and miss you and think about you. And it just warms all of our hearts to know that you are out there just living your best life with your family. We love you all so, so much. And we wish you nothing but the best. We love you, and mwah, that's from all of us. Bye.
Hi, Denise. Hey, girlfriend, I miss you, Jose and Emily and your sisters. You are such a survivor, you know, you're a good example to everyone here. You give us hope with everything. Next one.
Well, Angelica took my time, but I miss dancing with you.
Yes, that's true. Hi, Denise. I hope all is well. Angelica basically said everything that we want to say. We love you. We miss you.
We love you.
Girl. We love you.
Hey, Denise, Jose, little mama, how y'all doing? Hey, this is James. Congratulations, girl, and it was so good to see you at the Refresh a couple weeks ago. You know, let God continue to work in you and work through you, girl, and you continue to get better and heal. Love you.
Hi, Denise. We're so proud of you. We love you.
We love you, Denise.
Our ECMO queen.
Hi, Elisa. It's Melanie. How are you doing? We miss you. I hope you're doing well at home, that you're still walking, getting your exercise in. Everything's good. I saw the thing that y'all gave to Rick. That's so nice with the stethoscope and the little plaque. Miss you. Do good. Bye.
Hey, Elisa, congratulations. You're like an ECMO superstar around here. We're so proud of you, and we're so excited to see where you go from here. Take care, girl.
Hey, Elisa, it's Sam. I'm so proud of you. I'm glad you're doing well. Keep up all the hard work.
We're so glad that you're home. It's nice to hear you're doing well. Take care.
Well, congrats, Elisa, for making it out of the surgical ICU. I hope everything is going well. We're so proud of you. Congratulations on everything. We're so excited to see where you go from here. Good luck.
Hey, Elisa, it's Brittany and Addie. We just wanted to say how proud we are of you.
Woo! Hey, Elisa, it's Megan. I'm glad you're doing so well. Keep working hard and moving forward. Hi, Elisa. Heard you're doing great. Keep up the good work.
That
Nice.
was so good.
Wow.
So we're sort of, go ahead, sir.
I just want to say, I can speak on behalf of both hospitals because I practice at both, but some of those girls that were in the video from Northwest were in kindergarten when I started working with some of the other girls, the other
Yes,
senior
I understand.
nurses, and I can tell you, they are a fantastic group of people.
They
They
are.
really
I could not agree with you more on that. In fact, I've often said if you are in serious trouble, if you are just seriously injured or seriously sick, go to Houston Northwest. I'll just say it. I'll say the name of the hospital. I don't care. Because I'm going to tell, if you're up this way, if you're not up this way, you're down there, go to Methodist.
Yeah.
But yeah, it's pretty impressive at what that critical care ICU can do. It's amazing. So, Thomas, I hate to do this, but in deference to time, because we're running really short on it, the peer-to-peer conversation we were going to have, I think we need to abandon.
Okay.
Because there are a whole bunch of slew of questions
Nice.
that we've got. So I'm going to go to Dr. Bhatia first if I can. The question is from a physician in Europe, and they want to know what is the overall survival for VV ECMO in general and with this particular disease,
Okay.
the Legionella pneumonia.
Well, obviously, there's so many different conditions that the use of ECMO, VV ECMO can be initiated for. And so in somebody like Elisa's case, as long as the lungs respond to appropriate medical therapy, there's a very high survival rate. In instances where there may be cardiogenic shock or irreversible heart failure, or even irreversible lung failure, transplant is always a consideration, either heart or lung transplant. And in those instances, they follow the survival guidelines of transplant.
Mm-hmm. Very good. So, so do you believe, and another question for you, do you believe in weaning the vent or the ECMO first for your VV ECMOs? It's a follow-up question from the same physician.
Well, in most instances, patients have a trach, and so we like to wean the vent first, and then slowly back off on the ECMO and wean the ECMO, with the understanding that if we had to go back on the ventilator for additional support, we could do that.
Mm-hmm. Do you think it's, I just want to follow up the question. Do you feel it is easier to ambulate a patient just on ECMO without the vent or without the ECMO and a vent?
Well, I think it's probably equal. I think if you can be off the ventilator and you just have the ECMO machines to push with, with the appropriate help, it's doable.
Okay, very good. Vicky, Carlyle, a nurse is from New York, is asking, what about yearly and biannual competencies for ECMO training, nurses that have been adult ECMO specialist training?
So we are actually just getting our ECMO specialist program started with our course that will be starting up again.
Can
in
everybody hear
January.
Vicky?
Our ECMO specialists will be doing competencies quarterly with like a wet lab.
And they want to know, do you have any information about, because apparently they realized that we're running short. So do you have any information on the ECMO specialist school? Where can they find information?
Yes, so if you go to medaweb.us, there's a tab on the top that is listed, the Adult ECMO Specialist course. You can find all the information there. There's two options, of course. You can do the full program, which is the 2 days didactic courses live. And then there is the simulation section that also goes with the full course so that you can get certified. It fits the criteria for taking the certification test with ELSO. And there's also the didactic only. If you just want to learn all things ECMO, it's 2 days didactic, also live and interactive. Again, those will be starting back up again in January. And we have a lot of people been asking about it, so be sure to check on that soon.
Okay, and for Becky, this is from a perfusionist in Dallas. They want to know why you're using ECMO specialists when only perfusionists should run the ECMO. It's kind of a rude question, but I'll ask it.
Well, I feel that our profession needs help sometimes. It's 24-hour care. We're also in the operating room taking care of other patients, and sometimes it's a struggle to cover all of the time that we have to take care of these patients. And so ECMO specialists have really helped us in those situations.
Okay, and real quickly, let me go to one of Dr. Bhatia's questions, and I'll come back to Vicky. I think that was a good answer. I mean, look, the reality is, in fact, here's somebody that sent a message in, because these people are all sequentially sending the questions, so I have them. But so there's other people that are responding to this person, and they said we're only a hospital with 2 perfusionists. How the hell would we manage an ECMO? That was their response to the person that I asked the question about.
I mean, your cardiac program would shut down if you're manning that with 2 perfusionists for 24-hour care. You would be switching off every 12 hours with 2 people.
Exactly. Oh, that's a good question. Dr. Bhatia, how do you manage inserting a crescent cannula the way you did on this case if you don't have fluoro available?
Well, that's a good question. I would make sure we try to have fluoro. I mean, you're basically putting a very large cannula into through the IJ and into the heart, and I think doing it blindly is not recommended.
Yeah.
Yeah, I mean, I know some people say that you could do it with just TEE. I don't think that's wise. You have any thoughts?
I mean, if you truly didn't have fluoroscopy or C-arm, I guess that would be the next best thing, or potentially, doing this in a radiology suite. if
Yeah, or
possible.
what about sequential X-rays? Can you do it that way?
You could.
You could.
It
What is the biggest risk of putting that? That cannula carries a lot of risk on insertion.
Sure.
What is the biggest?
Perforation would be the first
Mhm.
foremost. Malpositioning of the cannula as well. But those are the 2 things that are really the things that we worry about when we're inserting these cannulas.
Mm-hmm. And Vicky Carlyle, question for you is, how do you manage hyperdynamic patients that have persistent hypoxia?
So a couple options there.
I guess hypoxemia would be more appropriate, but it says hypoxia.
You can use a medication, esmolol, that would kind of slow the heart rate down and kind of decrease the cardiac output, giving more percentage of blood going through your ECMO circuit. Some facilities would even insert a second circuit and have a dual circuit to accommodate the higher cardiac output from a hyperdynamic patient.
Mm-hmm. Or just a really big patient that has a
Sure.
really high native cardiac output, because you do have that as an issue.
Sure.
Yeah, absolutely. Thomas, how often have you, because I've done dual circuits before, but only once. What's your experience with dual circuits?
They're crazy. I've done about 5 of them. And when you come in to monitor these things, usually you've got different flows going sometimes, but that's not good. You want to have the same flow going. And you're trying to figure out mostly was on really the big patients. I think that was our major reason for having 2 circuits. That's the answer to your question.
Mm-hmm. Yeah, so I have, so let me finish these up. Here's a question. It'll just go to whoever wants to answer it. What do you say to hospitals that are just starting up ECMO programs post-COVID because they just want to start an ECMO program? They haven't had one, and now they're going to have one.
Well, so the first thing is you need a lot of electrical outlets because these machines require electricity. And that's just a fundamental part of starting a program. Next thing I look at is blood bank.
Mhm.
You need to have access to a lot of blood.
So, not getting into specifics, I think the tenor of this question has more to do with if you're going to start an ECMO program, you can't just willy-nilly start an ECMO program.
You
There's
really
a
can't do
lot
that.
to
No.
it.
You want to talk to people that have done this before, and that Joe Basha is an excellent resource. You can come to PerfWeb, and we will, you can talk to us about it. If there's anybody in your local areas, the bigger university programs, you want to talk to people that have done this before and that have, like we had a great talk describing everything that you want to ask before you go on ECMO. But I think we kind of covered that in the beginning. And these are all the things you need to know ahead of time. And it's things like your ICU space, your elevators. Are they big enough to move these patients around? How far are you going from an OR to an ICU? And little things like that are big. And then also just simple cannulas. Is the manufacturer willing to give you enough cannulas for your program? A lot of manufacturers say, nope, you can only have 2. Well, that's one got used up. Now you've got your standby one, and now you've got another ECMO that you have to do, or those are issues. And experienced programs can give experienced advice.
Well, that dovetails, and very good answer. That dovetails into the last 2 questions that we can ask, and they're just gonna both go to Dr. Bhatia. What is your view, and this is coming from someone in Europe, what is your view on centralized care like we have here in the EU?
I'm not sure what he means by centralized care.
Well, I think what he or she means by this is all of these kinds of high resource technological utilizing services are provided in one place in a big geographical area, that Elisa would not have been put on ECMO. She would have to go there for that.
Well, I think if you do go by that, those rules, you're going to lose patients, because patients like Elisa would not have had the time to be taken down to a centralized facility. I think, in addition to what Thomas said with regards to starting or maintaining an ECMO program, it's not only the logistics of moving patients from ORs to ICU. I mean, it's very much a team approach that requires intensive care nurses who know what they're doing, requires anesthesiologists, cardiovascular anesthesiologists who know how to use TEE. It requires a good perfusion team who can not only supervise assistance, but also be able to step in when need be for not only daily maintenance, but educational standpoint as well. So it's not just putting the cannula in. I mean, that's the easy part for us. But the difficult part begins afterwards in terms of the multidisciplinary modalities that are required to take care of these very sick patients.
Very good. And the last question that I have that I got from Magic from online had to do with anticoagulation. Anybody can answer it, but it was directed towards you, Dr. Bhatia. And this is from a physician's assistant in the Midwest, and they want to know what your anticoagulation strategy is.
Well, that varies between, I think, the people who are running the perfusion, the ECMO device itself. And so you all like ACTs to be a certain level and heparin to be a certain amount sometimes. Either, I don't know, you can comment on where you like the ACTs to be, but I've seen that vary from facility to facility. Some like the ACTs to be really out. Some are very comfortable with the ACTs to be, in a lower range.
Right. Which do you want to have the risk? Do you want risk of thrombosis or risk of bleeding?
Right. And so there's a happy medium somewhere between that. And I think we see that, I think at our facilities, we tend to err on the lower side of ACT management. And we've seen less bleeding in our patients
Yes.
because of that.
Yes, I agree with that 100%.
Right.
So, Thomas, what do you think about we wrap up because we've already gone 14 minutes over.
I'm going to go ahead and just cut to
I
the
knew
very,
we
very
would.
end. Yeah. I wrote this down, and I really thought a lot about ECMO as a four-letter word. We've really discussed a lot of things today. I mean, there is so much that goes into an ECMO. It's almost overwhelming. But in the end, we have to remember why we are here. ECMO is not just a four-letter word. ECMO is hope, 4 letters, for families. ECMO is heal for the disease process. And in the case of more and more patients, ECMO is life. And in my research of 4-letter words, I did find one more 4-letter word that kind of goes along with this presentation, and that is blog. At PerfWeb, we strive to provide content that is educational, relevant, digestible, and entertaining. And we give you CEUs for your time. Where else can you get this quality? Please like and subscribe our videos. It's important for our channel to get the word out. If you're so inclined, follow Denise's social media. We've given you all the links to her. She is an amazing woman, and her story does not end with this show. Her story is just beginning.
Thank you.
For obvious reasons, Denise and Elisa both have GoFundMe accounts. Any amount is greatly appreciated. On behalf of myself, I am honored to have this calling and to participate in the care of patients. On behalf of PerfWeb, I want to say a very special thanks to Dr. Bhatia for taking time out of his busy schedule for joining us today. And to Denise and Elisa, a special heartfelt thanks from all of us. Thank you for sharing your story. You have contributed more to perfusion education by being here today than you will ever know.
Thank you.
That was excellent. Thank you, Dr. Bhatia.
I'll say one more word about 4-letter word in ECMO, and it's love. Because we have to love what we do every day to get up and be able to take care of patients who are in dire need.
Yeah.
So I'll stop.
Yes, that's okay. Because I know with absolute certainty that both Denise and Elisa more me personally, who you exhausted me, Elisa, exhausted me, okay? And Denise, I have no doubt you exhausted a lot of people. But I shared Dr. Bhatia's and Thomas's, Becky's and Vicky's feelings and passion, and I have plenty of time to rest later. Thank you.
Thank you.
Okay. Well, that's our program. I know we ran a little over. Please forgive me. But a round of applause for this incredible group of people. Okay. We'll see you next month for PerfWeb 97. No? When do I see him? Oh, see you next year for PerfWeb 97, January. Look for it. Be safe. Bye.
Bye.